So today we're going to go through a couple reminders from the training team. Then we'll talk through some patient scheduling capabilities, care everywhere, and we'll round out with consents. And this will actually mark the end of our initial content for town halls, but we will continue these through October with a little bit more focus kind of within the topics. We'll rearrange some of the topics and just kind of give another overview because I know there's been a lot of information. Not everyone's been able to join everyone. So You'll see more invites come, but this is the kind of the end of our core content for today, which is exciting. And with that, I'll hand it over to.
So if I understand this correctly, Caroline, what we're going to be doing then is kind of going over some stuff we've gone over before, but maybe a little more detail. And we will either the day of or the day before that send out what we're going to be going over so folks can pick and choose in terms of whether that's something that they feel like they want to learn a little bit more about.
Exactly. Yep.
Okay. Sounds good.
Okay. All right. And with that, I can hand it over to Caitlin from our training team.
Hi, everyone. I am here just to give a reminder about the 3 steps in the physician training or provider training process. The first step is login labs. For non-providers, this is something that's completed at the end of your class. For providers, this is something we need completed before you arrive to class or before providers that you work with arrive to class because they need to use production and log in to create some user settings in production during their class time. So this is something, it went out a couple of weeks ago from Shane in an email packet where providers were asked to complete this by September 19th. We know that is tomorrow, and so we'll start some more communication or offer some additional office hours or additional support over the next couple of weeks to get everyone there before the class that they'll attend.
And just by the way, I'm looking at my calendar, Caitlin, and I see for myself, and I think we had this sent out to our medical staff, office hours that on your calendar will show up as optional Epic Lab login office hours. And I'm seeing Tuesdays and Thursdays from 7:30 to 8:30. That would be available to reach out to someone at Epic to help out with anything regarding login help. And I think for a lot of folks, they're going to find this really helpful. So just keep that in mind.
Yes, there is on the next slide, there's 2 different times for office hours on both Tuesdays and Thursdays, 7:30 to 8:30 and 12 to 1. I believe all 4 of those calendar holds were sent out to providers early this morning or late last night. And we'll continue those up until go live. But if someone isn't available in those times and still has some questions, they should definitely still reach out to the email address in the packet that they received or epictraining@cghmc.com, and we can get them to the right spot.
Hey, Caitlin, if you could have someone take a look at the 12 to 1 slot, because I'm looking at my calendar for Tuesdays and Thursdays, and I see the morning one, but I don't see an after the 12 to 1 on my calendar.
Okay. I do see Hank on, so I'm going to give that follow to Hank, and then we can continue the training portion back on the last slide, Caroline. But yes, we will take a look at that, Dr. Byrne.
Thank you. Appreciate it.
Mm-hmm. The next step in preparing for class is the 100 level independent learnings in Epic U. So these are a series of e-learnings or videos directly within Epic U at training.epic.com where you will watch maybe 5 to 10 videos that are between 2 and 10 minutes long and see a foundation of Epic before you come to class. So for someone that is an outpatient family medicine physician, they'll be introduced to finding their patients and reviewing their chart, familiarize themselves with the Epic screens. They'll start to think about writing notes and placing orders, some in-basket things. And then when they come to class, the 101 class, they'll build on that foundation and do some of those more complex workflows, things that might draw a couple of additional questions and put it all together. And so those 100 level learnings need to be completed by a date depending on their specialty. So cardiologists and proceduralists and oncologists should complete those by tomorrow, and we'll start reaching out on a class by class basis. Every other provider should complete it by October 1st.
I would just, sorry to interrupt again, Caitlin, but I would just add something else from someone who has done the 100 level learning classes. Plug in also, try to plan to do both the watching the videos and taking the assessment at the same time. Because speaking from someone who wasn't able to do that, if you do that a number of days afterwards, it's tougher to retain that and take that assessment.
I like that. Both the independent learning and the assessment are required before class starts. Something that can be helpful, Dr. Bird mentioned, it was hard to necessarily retain all of that information before taking the exam or maybe before even attending class. There is an opportunity to continue to practice in the playground in between those learnings and the class at CGH to continue to retain a lot of that information. So there are some opportunities for guided practice there as well directly in Epic U. When providers then arrive at CGH for their class, that's a 101 class. It's already scheduled and providers are registered for those for some time after next Monday, September 22nd. Many of those are in the last 2 to 3 weeks of October. And in that class, they'll have an Epic trainer present that will walk them through a majority of workflows and also through efficiency tips and tricks. So they'll get to go through how to make their workspace efficient while saving off a user version of an order or a user version of a note or something else that's specific to that specialty. Any questions about what to expect for these 3 things? Okay, awesome. I know Shane has sent the packet out with some of this in step-by-step instructions. If you have any other questions, there's specific follow-up emails and contact information next to each step who's the right person to reach out to. But let me know or let an EC or AM that you work with know if you have any questions or how we can help.
One other comment I would make is it is just really important to get the most out of your 101 class, to have shown up to it having done those first 2 things. Don't want to be wasting your time doing some of this other stuff before you can even start the 101 class. Your ability to catch on and do well with Epic depends on starting now with having some of these things in place before you show up for that 101 class.
Second all of that. Thank you, Dr. Bird. Caroline, you're up.
Awesome. Thanks for jumping on, Caitlin. We'll move along to our next topics. Moving past that, we have someone from our patient experience team here, James, to talk a little bit about patient scheduling and how that's going to look different come go live. So, James, if you want to take it away on this slide.
Yeah, for sure. All right. So for patient scheduling, obviously patients will, once we go live with our MyChart app, they'll have access to a few different scheduling options from within that patient portal. So I think we've talked about this in the past, but the patient portal itself will actually go live on October 20th. This will be the soft live period where patients will be able to get the app, view some things, but they won't really have that full access. So beginning on November 2nd, our true go live date, they'll get that full access. And as a part of that, they'll get their scheduling options. So patients will have access to directly schedule in the primary care specialties. So that's the family medicine, pediatrics, and internal medicine. So that'll be open, whereas a patient that may not have a previous relationship with a provider in one of those areas, they can go onto the app and find a time and just directly schedule. Directly scheduling, or the direct scheduling itself, is if the patient does have a previous relationship with the provider, they can search based on that provider and select times from them. And then ticket scheduling, which is if they have, for example, a referral, they can go in based on that referral and then schedule themselves an appointment. Also, we can, I guess the second part here is that ticket scheduling. So for any of those specialties, that won't be limited just to those primary care pieces. The specialties with the follow-up visits will also be enabled for that ticket scheduling. And then once the primary care has stabilized with open and direct scheduling, the patient access team, so those folks will work with our leadership team and specialty providers to see if we want to expand those capabilities. With that, I'll hand it over to Beth, who's going to do a quick demo of some of our scheduling functionality.
So I'm in a testing environment. So just to know that some of this is, all of our templates are built in prod. So some of this might not look exactly how it's going to look. Let's go ahead and share my screen. Okay, so when they come into their MyChart account, they can up top, they're going to see where it says schedule appointment. And since I've already seen a provider before, I can go into here and say, I need to follow up with my primary. And it's going to just let me choose that time then, because I've already seen him and established with him. If I hadn't seen him or established with him, I could, or if I need a new provider, I could go in and say, I need a new provider. Again, we have more than just this, but again, our templates are not in every environment. So some of those templates aren't in there, but I can choose a physician then from another department by choice. We also can do labs. We can schedule a mammogram. We can self-referral ourselves and schedule a mammogram. And then we also have what we call find urgent care. So if we go in here, we have downtown and Dixon, and I can say that I'm on my way, go ahead and e-check in, and that puts me in a queue that the physicians know that I'm coming. We also are going to have a new feature called Provider Finder. So if patients were to go out on our website without even having a MyChart, they can also schedule from there. So we'll have Provider Finder, say I need a family medicine doctor. It's going to list our family medicine doctors and then their schedule that they can just go ahead and schedule to. They don't have to be a patient of CGH or already have a MyChart. They can schedule without doing that with our primary care doctors. Anyone have any questions on our scheduling? No? Anything else anyone wants to see?
I think we covered this in other meetings, but just to clarify, that ticket scheduling is an optional thing that any of our physicians can offer to their patients. They don't have to offer ticket scheduling at the time the patient is, leaving that clinic. Just so we're clear on that.
James, clarify me though. So right now we had every specialty and every doctor scheduled for ticket scheduling. I don't think they can choose by what they do. I think it's built on the back end. So I don't clarify.
Oh, I'm just saying that, like, when someone leaves your office, I'm pretty sure, I just want to clarify this, that they just have to click a button that says they're allowing ticket scheduling for that follow-up. And if they don't, I'm not sure that ticket scheduling happens in that situation.
Okay. Yeah, I'm not sure the doctor workflow, so I'm not sure.
Yeah, I think that the provider themselves would have to put in that order for the follow-up, but that's something we can follow up with our patient access team for sure on.
I'm pretty sure on that one.
Yeah, we allow on our end, so as long as it's allowed on our end, I don't know how the process works like on your end. I just know that we allow it, so I don't know if it automatically or if you have to click it.
Well, they can't schedule the follow-up unless there's a follow-up appointment request order placed. But the new patient, that's just for primary care that can be unsolicited without an order, right?
Yes, and primary care doesn't need a ticket for a follow-up appointment either. So primary care can do a follow-up even if they've seen them before. There's rules built in there. So they can just schedule a follow-up without a ticket. But for specialties, it has to have a ticket in there.
Okay, thank
And
you.
like for x-rays or MRIs or CTs, if the doctor orders it, it'll send a ticket to the patient that they can just schedule it through MyChart as well for certain tests.
Sounds pretty slick. Thanks, Beth.
You're welcome.
Yeah, thank you, my chart team, for jumping on. Any other questions about scheduling at all? All right, then we'll move along to the next.
Yeah, sounds good. Hey, everybody. For anybody who hasn't heard from me before, I'm Hank Menz. I'm the application manager for Care Everywhere and Link. And yeah, we just have a quick slide and then a quick demo after this slide. Care Everywhere, for anybody who hasn't heard of it, is our platform for interoperability. This is how you can bring over information from external organizations and also how you could push information out. So any organization on Epic, like Northwestern, OSF, etc., is on the Care Everywhere network, and you'll be able to connect with them pretty easily. We also connect with some third parties to be able to connect with a greater number of folks who are not using Epic as well. In terms of what physicians will be able to do, you'll be able to bring the data in and reconcile it into the patient chart. So part of the demo you'll see is seeing this information come over and being able to reconcile patient level information. So that's including allergies, meds, problems, and immunizations coming from external systems. So once the data is reconciled, it really serves the purpose of enabling clinical decision support. Not only can you see that it's come over, but you can see that this has been verified by the patient, it's been verified by the provider, and it can be used for future decisions going forward. In time-sensitive situations like acute care settings, you also have the ability as both clinical staff and a physician to query for a patient's records from another hospital. So that will be once again part of our demo. That's really all the background that we really need to give on Care Everywhere. I can go ahead and steal the screen. Okay, so we are in an emergency department encounter with Diego Hoff. We are on his triage tab, and we see 3 organizations that he already has connections to. So we can pretend like these are other Epic orgs, and one of them requires authorization. So we discussed with a few different folks so far about this, but a decision came up of whether we were going to have end users themselves be able to collect consent or allow the patient to collect consent and document that. And the answer was we were going to keep that security instead of having the front desk do this, because usually, even if it's not an emergency department encounter, let's say it's an outpatient encounter, a lot of the times when you are querying for an outside organization because your patient says they were seen at Northwestern, they were seen at OSF, they're already going to be in the chair. They're not going to be telling that necessarily to the front desk. And so that's why we really give physicians the ability to query through Care Everywhere. So we see connections that have already been established, and Metro Medical Center has a consent policy that is a little more strict than the other ones. So we have to obtain the patient's signature. This form comes through Care Everywhere, we can say from Northwestern. So it allows you to kind of collect authorization or consent on behalf of whoever you're getting the data from. Once you do that, the information is going to come through Care Everywhere. Now, we have the list of organizations that Diego has been seen at and that we have information coming from here on this screen, but he's also saying he's been seen at other, additional organizations. So if we want to manually search for and find those, then we can go to outside charts in the top right of the screen. And here he says he's been seen at Great Lakes Health System across the board in Wisconsin. So we just select that box, appears in the top right, and we can click search here. And so we're going to get a return. Basically, what Care Everywhere does when you query, it looks to the other system on the network and just sees if they have enough matching patient demographics to cross the threshold of saying, yep, this is the same person. We're going to connect these records and information is going to flow bidirectionally. So the trigger of actually linking these records is not the match itself, but us verifying the match. Yep, this is correct. This is clearly, if these are two different people, then one is just impersonating the other. So any differences in their demographics would be highlighted. So if you had a slightly different address or maybe a nickname, then that's an example that could be called out. So I'm going to say this is yes, correct patient. And now we have data coming over from Glacier Edge Clinic. Next, I'm going to go to chart review. And while we're in the Encounters tab, we are able to see this icon next to a few of the encounters. This is the Care Everywhere icon, and anything that it's next to means that it is external information, external data. You can single click on any encounter to see where it came from. So we can see this came from River Hills Health System. You can also hover to discover right over and get that little pop-up. You can see pretty small text. And while in this demo, we have just the Encounters tab, the notes, imaging, media, PDFs and scans coming through, all of those tabs can have Care Everywhere data on them for you to be able to view. The last part of this, so this, for the sake of this demo, we're going to access the Reconcile Outside Information activity a couple different ways. One is this Care Everywhere toggle. So this is a great resource to hover over. Say you don't want to see any outside data, you just want to see data from CGH encounters, you could just turn it off. It'll filter everything out. But if you want that full view of the chart, you keep this on. And hovering over here, you can update or refresh connections if you know they've had a recent encounter and maybe you're just not seeing the most up-to-date data. If they say, hey, I've been seeing it even more organizations, you click that familiar Find Outside Charts button. But we also have a pop-up here to reconcile outside information. So remember from the slide that problems, allergies, meds, and immunizations would be able to be reconciled. So here we have just allergies, meds, immunizations, and I'm going to click this plus sign and accept. That is all I need to do to reconcile something. You'll notice sulfa drugs is listed here, but in the storyboard here, which is considered a source of truth, we don't see it. So we're really enabling this for clinical decision support when we click accept. And you can see that's going to now appear on the storyboard as verified information on the patient's chart. You can also reconcile medications. When you're trying to reconcile a medication, for a lot of them, it's going to make you verify the details of that medication's administration and dosage. So we can verify here with the patient that this is still good. There's no end date to it. And we can keep on going. I'm going to interrupt myself, though, and say, I would say this is the biggest annoyance for users at Go Live as it relates to Care Everywhere. Specifically with a ton of medications coming in, that might not be super applicable, might be a little out of date. We have settings in our system that aim to avoid that as much as possible. If it's a super old medication without a start date, for example, or sorry, not a start date, without an end date, then that is likely going to drop off. If something has come through Care Everywhere and been discarded, then it comes through again from another organization. We have settings to kind of auto discard that. So even with those settings in place, I always give the warning that first couple weeks of go live, there will definitely be some annoyance around this, but it is a very important activity. We will also have tip sheets distributed for this on our Learning Home dashboard. I think with those non-applicable medications, sometimes you could have, for example, like 20 on a screen and only 3 may apply. That's an extreme example. But to make things go quicker, let's say this immunization is applicable, but these 2 are for some reason not. I can just discard anything I haven't selected instead of having to individually select. So that discard remaining button that's now grayed out, that's an example of kind of a quick shortcut. Saves a lot of clicks. Okay. So I have accepted that. And I just want to highlight that with physician security, you are able, looks like it's taking a little while to load here, but, oh, sorry, my screen caught a bug from Caroline's, I think, and started glitching, but we had patient Diego Hoff. Okay. What I'm trying to showcase here is that as a provider or a physician, you have that extra security to reconcile problems, whereas your clinical staff will only have the ability to reconcile allergies, meds, and immunizations. So added security for physicians to be able to do problems. And that's the Just to Care Everywhere. I know that was a lot of me rambling on kind of how it looks in the system, but looks like Kevin has a question, so go for it.
I have a lot of questions all the time. So you showed how it looks for ED. Does it look different for the clinic side, the outpatient side?
I would say from a chart review perspective, so going back into like the different tabs, it's going to look the exact same. It looks like we don't have a ton of data for this one, but in terms of the chart review and the reconcile outside information and querying, the 3 most standard workflows for Care Everywhere, it's generally going to be the exact same. I think there are certain like outpatient specific activities and inpatient specific activities where these can pop up, in different places, but I would say the core of it remains the same throughout. I see another hand up. Go for it.
How do you access imaging from an outside facility?
In terms of accessing imaging from an outside, so you can just go to the chart review imaging tab. And I'm really glad you asked that question, because we have something called Happy Together Imaging. Whenever you hear Happy Together, it's literally just being able to see outside information in chart review. You're always going to be able to see external imaging results, but whether you get to see the image itself, like if it was an X-ray, that depends on setup done by that outside organization. So for example, if Northwestern has done, and I can take this as a follow-up, if Northwestern has done a certain level of setup, then images, DICOM images that they have stored in a VNA or a PACS could come through Care Everywhere. But if they have not, because I'd say that's a newer, relatively newer functionality that we're having Epic customers adopt, then you'll just see the result without the image. This patient does not have the actual imaging result, so, but this is the tab where you would see it.
That's good to know, Hank. So if you could, when next time we get together, if you can just at the beginning of the meeting, either Hank or you can give the information to Caroline, what organizations around us will we have access to those images? That would be great to know.
Absolutely.
Okay. Will it go both? Will we be, or I can't remember, are we an organization where our images will be able to be shared with other organizations?
Yes, we're integrating with Fuji to be able to share cardiology and radiology images out.
Okay, very good.
Any other questions? That was the end of my demo. Oh, looks like we have... Oh, that's not a hand up. That was just another person joining. Well, thanks for lending your ear. And this probably won't be the last time you're hearing from me before Go Live, but I'm excited for Go Live and excited for what this can do for CGH. So hmens@epic.com is my email. Always feel free to reach out with questions.
Thanks, Hank. Very good.
Thank you, Hank. All right, we're on to our last topic for today. We're going to talk a little bit about consents. We have Bennett on from our radiology team to talk about that.
Last but not least, and certainly the best and most favorite topic. So let's talk a little bit about consents. But before we do, I actually have an answer for you guys as far as Northwestern, as far as advanced image exchange. They're actually in the process right now of undergoing that advanced image exchange implementation. So within the next couple months, Northwestern will actually be live on that advanced image exchange workflow, and we will be able to see a lot of those images for those patients seen at Northwestern. If you guys want to know any other key organizations that we send a lot of patients to or we see a lot of patients from, let me know. And I can generally answer that just by kind of looking up where they are in the process. But I just happen to know that answer because I'm on the Radiant team and I track a lot of that stuff, so I can tell you guys where it's at.
Yeah, that'd be great. You just draw a circle around us. Again, those are the places those are the places we're interested in.
Yeah, you got it.
Okay, thanks.
But yeah, no problem. Like Hank was saying, though, we do advise all customers these days move to the Advanced Image Exchange framework if they are able to, or if their PAC supports it. So we're pushing more and more organizations to do that. So even if they aren't live currently, there is, like I said, a pretty big push internally to get most organizations live through and have those features. So if something isn't, I wouldn't be surprised if that changes relatively soon. Okay. So on to consents. So what are the big things that everybody needs to be aware of? So we are moving from paper consents, as you guys probably know them, IMED consents, to electronic or e-consents within Epic. There was a big project that we did as part of this CGH implementation where we ported over that data from IMED to Epic for those consents. So that was no small undertaking, and we did that for all of the procedural areas, so meaning like radiology, endoscopy, for the OR, for cardiology, the cath lab, ambulatory, any area that basically uses those IMED consents. We took all those consents and we brought them over to Epic so we can use those in an electronic format. So it will be a big change for the organization, but it will be hopefully a nice one because people will be able to access all this stuff in line directly in Epic. How will that be captured? So we're going to capture those via a term that we call welcome, which is really just an iPad. See it as that, right? We are able to pull up in those consents on an iPad or via MyChart Bedside, meaning like on a phone, right? On your actual phone, you can pull up MyChart Bedside. Or, like I said, welcome via the iPad will be the primary way that folks do this. And the consent will appear on that iPad and patients can electronically sign using their finger on that iPad. It's going to be a really nice way to do it. We chose iPads obviously via the Welcome platform because it's big enough, right? And people can see it. It's mobile. You can move that thing around, right? We don't have to use like Topaz e-signature pads that are chained to a computer, right? Things along those lines. So hopefully it'll be a nice, easy way for folks to do this. One of the things that people need to know, and thanks to Karen for reaching out to our legal folks like Ed and Liz and figuring this out today, I did include a little blurb in the lower left-hand corner for this as well, but consents are valid for up to 90 days and can be initiated by the physician's office. The little blurb there is from your internal like legal documentation on the lower left side as far as like what that actually means and how it's documented for you all at CGH. I just list like a quick little sentence in there as far as valid up to 90 days, but there are a little bit of stipulations around that you guys can read in that little blurb there. But more or less, that's the time frame you should be concerned about. Verification needs to be done by the physician on the date of service, validating that obviously there's been no changes to the patient condition since the consent was signed. So that's how we use those 90 days and making sure that it's valid and there hasn't been any changes, right, for those consents that are signed within that time frame. So any questions on that before I show you a little bit of what this looks like in the system? Can everybody see? Just give me a thumbs up or a yes if you see a pre-procedure navigator.
Looks good, Bennett. Okay,
great. So every application's workflow and how they gather consents is a little bit different, right? Whether that's a case-based workflow or an appointment-based workflow, maybe it's pre-procedurally, maybe it's intra-procedurally right before the procedure starts, right? For inpatients ahead of time, it might be gathered in the ambulatory office. But how we get those consents as part of the workflow is generally the same, even though the application workflow might be a little bit different per area, and that's perfectly okay. What people have access to, and in my example here, I'm using just a pre-procedure navigator. I have a colonoscopy here scheduled with Dr. Monty, right? And I am the nurse as I'm logged in right now, or I could be the provider. We see the same kind of settings. And I need to gather this consent pre-procedurally before we obviously do the procedure with my patient Penelope. I'm just going to navigate to my consent section of my navigator here. I'm able to add my consent. And when I do that, I see all the consents that might apply to my area. You can see here, I've narrowed it down to the endo-specific consents. These are the ones that would be available to me as a GI nurse or a GI doc. So I'm only seeing the ones that are relevant to me, right? I'm not seeing ones for cardiac catheterization. I'm not seeing ones for CT-guided liver biopsies, right? I'm just seeing the ones that are relevant to me. And you might notice that these things should be, at least in name, a little bit familiar to you guys. These are in name the way that they would have been labeled in IMED as well. So like I said, because we ported all these over from IMED to Epic, the naming should be fairly familiar to all of you guys, and you should be able to pull open the right consent just based on name. If you got a large list, of course, you can search based on the one that you're looking for here, but for the most part, all of our applications have narrowed this down so you're seeing the right consents that are available to your area. In my example here, I'm going to say I'm doing a colonoscopy, but I'm going to do a banding hemorrhoid with it under moderate sedation. When I do that, I'm getting a form here, right? My consent form should be, again, very familiar to you guys because it should look fairly the same as it did in IMED. Here I can see what procedure I'm doing, who the physician is, and then you'll see all this specific information here that's on this form. And all this information that's on this form here should be the same information that was in IMED. Why? Because we copied and pasted it, right? So all this information on this consent, again, is going to be the same information that was in IMED, so it'll look very familiar to you all. And then what we'll do is we'll have the patient sign it, right? They'll be able to sign this on the welcome tablet. When they do that, their signature is captured on the form, right? If we need witness signatures, we have that, and we have provider signatures. Right here, as I'm logged in as Laura Shipman, I'm able to sign as Laura. This could be Dr. Monty as well, obviously, if he was signing for this particular consent. And after I have all those signatures captured, I'm good to go, right? And my consent is there. So now I see in my navigator, if I already have a consent, right? I see my signature status, right? I need one more signature on this thing. When I received it, right? I see the date in here. I can always edit this information if I need to. and I can update this information, or again, just view it, right, and see what this thing looks like based on what I already filled out. So hopefully this isn't like too scary for anybody, right? We tried to make the process as simple as possible as far as making this consent available in Epic, and having what you need there. You can see here when I created this consent, what does this thing do? What's that neat little thing, right? That neat little thing is a QR code. That's what I'm going to use to scan with my welcome tablet. So it pulls it up instantly on my form. Or excuse me, so it pulls it up directly on the tablet. So when I have this, it's not like somebody needs to type in the patient name or MRN or birth date or all that information. This will be specific to this consent for this patient. So I'm able to assign the tablet and pull up that tablet just by hitting my little button here that allows me to do that once my consent form has been created. So hopefully it's an easy way for everybody to do it, right, and get those signatures. And it also gives us kind of a nice way on the Epic side to audit this too and say, hey, here's all my procedures, over the last year that have a consent of this particular type. Here's the ones that didn't get one for whatever reason, right? Most of us have checks and balances to make sure that we are. But if we ever did miss one, right, we'd be able to audit that. And it's really nice to see that information. Somebody asked me a question the other day, and I can't remember who, and I wish I could give you credit. If it was you, you can call yourself out. But someone said, like, what happens if it's a procedure that we don't do hardly at all and there is no consent for it, right? We have general, like, procedural consents that aren't, or are more like generic if we needed to use it, or nothing would stop you from actually still accessing that form in iMed because it's still going to be there, and you could pull it open as a paper consent and have a patient sign it and then to scan it in if you needed to. So I wanted to make people aware that like that is available in a emergent situation, right, where we didn't have something available for you. So just know that like there's always a way to get around that and get that if you needed to. Otherwise, we're expecting that everybody uses these e-consents because, again, we want to capture this electronically. It's an easy way to capture it electronically. We want to be able to audit this, and it should be easy for everybody. If there are things missing, let us know at GoLive, right? Put in tickets how you normally would. We'll add consents as need be. And update things if we have to. Otherwise, we've gone through a pretty rigorous process of, again, porting over that information from iMed and also having some of our clinical folks, our nursing staff like Corinne, Karen on the project team who are also nurses, review these forms and make sure that we have the right information available in these forms, as well as making sure that it's legal. And we do have that information included in these forms. So I'll pause right now. Any questions about this process? Kevin, I see a question, a hand up.
I am a questioner. So in your previous slide, you showed that the consents are good for 90 days or in some exceptions indefinitely or a year. When we're collecting consents, are we going to be documenting that as an expiration, or are we just going by the date it was collected and then calculating?
So you would go by the date that it was collected and then calculate, right? So we're always going to show you that date as far as like when it was generated or received. And then you could calculate based on the own legal policies. Generally, like I said, it's going to be 90 days, right? But in those circumstances, like I'm reading a lot of like chemotherapy stuff in here, right? If you're somebody that works on Beacon, right, and you're doing a lot of the chemo stuff, I'm guessing those users generally know what the differences there are. So they might treat it a little bit differently, but generally I rely on, my clinical folks to know, okay, this is good. We're 90 days, we're fine. Or if it's, something with a blood product or something with chemo, and it maybe is a little bit different, they can just calculate it based on that date. Well, good. Well, thank you very much for your time and attention. And I look forward to seeing these electronic consents in Epic. It's going to be a really neat thing.
Awesome. Thank you for joining, Bennett.
Sure.
All right. That's all the content we had for today. So we can let folks go a little early. Dr. Bird, is there anything you want to call out before we drop off here?
No, we'll just keep doing these and we'll kind of regurgitate some of the topics, but we'll keep going. And I think we'll give people some of their day back.
Perfect. Thanks, everyone, for joining.
Thank you.